Good afternoon, everybody. Welcome. Today we're going to talk about COVID vaccine and answer any questions that anybody may have. We have Terry Glenn, Margot, Dr. Emerson, and Tony Tedesco, Clearwater.
All right, thanks, Jasmine. Looks like we have a fair number of folks watching so far. So we'll go ahead and get started. First of all, thank you to Chief Tedesco and Lieutenant Glenn for joining us. I wanted to bring in a few more perspectives on the information that we go through here. I'll begin with our usual update as to sort of where we are in the epidemic curve. Here it is. Hopefully you guys can see this. This goes back to really the beginning. You can see we had this big, huge spike here in July, which went back down, and then we've sort of gradually been rising through the fall. And now we're really much more steeply rising here over the last little bit. Concerns obviously are related to the fact that over the holidays, we would expect less people to go get tested, but we were in fact testing record numbers of people at our public testing sites over last weekend. Cases, as you can see, we've had several days that are higher, but all but the two highest days back in July. So things are not great in terms of the case counts. You can see our percent positivity for the week was 7.5. I can tell you that we've had several days over the weekend and the beginning of this week where percent positivities in Pinellas are closer to 12%. We are not alone in this. This is happening across the country. We were actually a little bit delayed in getting this second peak, but it seems as though we're getting there now. And there's still whatever happens related to the holidays that we still need to take into account with this. As far as the impact on our hospitals, there are 70 or so people in the ICU in Pinellas County today with COVID, actually 75. And 39 of those are on ventilators. That's a huge number, more than we've seen previously. So over 50% on ventilators. We were seeing like 25% on ventilators. So not only are they in the ICU, but they're clearly getting sicker as well. You may know we have one hospital in the county that does ECMO, which is like the heart-lung bypass machine, and they are maxed out at 12 patients on ECMO right now, which is about as invasive and heroic type care that one can do, and that's a lot of people. Just a week or two ago, we only had 2 or 3 on ECMO for the county, and now we're at 12. So you can see that that's not going too well. Again, this is not isolated to Pinellas. Our surrounding counties have similar shapes of the curve, and even across the country, you've been seeing things in the news for a while, and even across the ocean. I was on a call today with one of the lead physicians for EMS over in the United Kingdom and the UK. And she mentioned that just a day or two ago, there was a day when London Ambulance Service was holding 500 emergency calls and another 800 non-emergency calls. They have run out of BiPAP machines. They have run out of ventilators. Their ambulances are sometimes holding patients at the doors of the hospital for up to 7 hours. Now that wave that they've seen intensify over the last few weeks is largely related to the new strain. Now, the new strain is, as of yet, not shown to be any more deadly, but is certainly more contagious. And so each individual that's infected is infecting more people with it, what sometimes... but it's certainly more contagious. Oops, got a little echo there. So what's sometimes referred to as the R naught is significantly up and has really spread in a wave across all of Britain over the last few weeks. So they're hurting over there. She was painting a very dismal picture, and I really felt sorry for her and what they're going through over there based upon the information she was sharing. they are experiencing some very rough times over there. We have seen things getting close to that dire in a few places in the U.S., but not to that level. And I certainly hope that we don't. But it's not out of the realm of possibility over the next month or two. And I know I'm very sick of sounding like the doomsday guy over here, but the shape of this curve is not encouraging right now. And if what we're seeing happen in Europe is any indication of what we might see over here a few weeks or a month from now, that will also be very unpleasant. We've seen it in the past. We've seen Europe lead us where, and then we follow along a little bit later. So I certainly hope that that's not the case, but I don't think it's out of the realm of possibility. In talking with our hospital leaderships teams, every single hospital is having some struggles related to staffing. You may see numbers about how many ICU beds we have or how many hospital beds we have. That's not the same thing as a staffed bed where somebody can care for you. We are seeing offload delays. We are seeing system status management. Most of our hospitals are on lab confirmed COVID divert. Just as a reminder to the Pinellas County folks, that means nursing home patients with confirmed COVID. That doesn't mean people out in the community. And it's worth noting that on my shift the other day, I certainly saw that more COVID patients than I have in quite a while, and I was not working in the COVID area of the ER. And they were by and large from the community, not from facilities. So they were not nursing home patients or assisted living patients. They were out in the community, and now they were coming in not just with COVID, but very sick with COVID. I mean, I had to put a few of them in the ICU. The hospitals are definitely feeling the strain, and so we are right back in that same zone where we were before, where although you might not get injured or personally end up in the ICU or very sick from COVID, your care for a stroke or a heart attack or a trauma is going to be impacted if it's not already in the very near future by how stressed the hospitals are with COVID. So not the most uplifting or positive COVID news today. And so I think maybe I'll just pause there for a second and take any questions about where we are in the curve of this thing before we get into the vaccine itself. So I guess first of all, from Lieutenant Glenn or Chief Tedesco or Jasmine, any questions from you all? And then we'll see if anybody wants to put any questions in the chat related to sort of what's going on with the virus.
Well, Dr. Jameson, I'm sure that we're going to have a lot of questions come up now if you're saying it's a new strain that's in the UK. Is it going to be effective with the vaccine? Or is the vaccine going to be effective on that?
Yeah, that's a great question. And that's the logical first question, right? Because we're all looking to the vaccine as a way out of this thing. So the, sorry, let me try and share something here to help with the explanation if I can. If I can find the right thing I'm looking for. Here it is. Okay, I got it. So this is the spike protein. And you've heard a lot about the spike protein in the news or wherever else, but this is what the spike protein looks like. The view on the left is it's standing up straight view, and the view on the right is looking down on it from above. This is a 3D model of what this looks like. And remember that proteins are made up of these amino acids or peptides, and they kind of fold themselves up into certain areas so that they have a particular shape that they can then interact with the receptor on your cell. In this case, it's the ACE2 receptor, which is the angiotensin converting enzyme number 2 receptor. And you can see that there's something there labeled the ACE2 binding domain. and H usually in these stands for human, ACE2 binding domains there. And that is really like equivalent to the teeth on your key that fits into a lock. And so although you can have mutations anywhere in the virus that might change the way the envelope of the virus looks like, what is equivalent to like a cell membrane, that might change maybe this part down here on the other end of the spike protein. If you have a mutation that's right here at the binding domain, it tends to make it either more or less able to bind to that receptor. And if you get a significant mutation there where it can't actually fit the lock anymore, then it kind of dies out on its own, right? Because it can't infect you. Now, you can get one there that makes it fit the lock a little bit better. And we've seen that. We saw that last spring with the first mutation that we all talked about. And now we're seeing it again with some of these new strains. But as long as that key stays generally the same, such that it can fit the lock, the vaccine, and the vaccine, again, makes you make this protein here for your immune system to recognize. That's all the vaccine is. The Pfizer and Moderna are the code for this protein packaged in a little drop of fat. That's all they are. It's a little bit of RNA. So as long as, I guess the best way to say it is, if the virus mutates in such a way that the vaccine wouldn't cause immunity to it anymore, it would also likely mutate in the same way that it would not be able to infect you anymore. So there is nothing at this point that makes us think that the vaccine will not be effective against this new strain that they're seeing in Europe. Now, there's a couple of mutations associated with the strain in Europe, and to get into the specific bases, if you remember how DNA and RNA work, or the specific amino acids that have been substituted, is probably beyond what we need to go now. But you know, this spike protein can change a little bit and still work. And if it changes just that little bit so it still works to infect you, the vaccine will also still work. If it changed to such a degree that the vaccine wouldn't work anymore, likely the virus wouldn't be able to infect you anymore either. So I guess I'm not sure if that made sense or not, but the fact that the virus still uses this same general spike protein, which is the same thing that the vaccine has, means that we do not believe that the virus will be able to get around the vaccine at this point. I'm not sure if I did a good job or a bad job with that explanation, Lieutenant Glenn, but
no, I think it was a good job. It made sense. That's for sure.
All right. So, you know, I know the mutation sounds scary, but right now we're not seeing anything that is like, you know, the world is ending, like back when we thought, well, you might be able to get infected multiple times with this with zero residual immunity. So that's kind of where we are with that. What other questions do you guys have?
So they started vaccinating just a little bit before we did. So
They who?
In Europe, and we're talking about in London, right? Is that where?
Yeah. So they started like a week before us.
So there should be data coming out on this vaccine and people getting infected, right?
Yeah, and I think we'll begin to see that pretty soon, not only there, but over here. Remember, you have to get a certain number of people who have the vaccine in them and then subsequently get infected to know that, or know that won't happen. So that's worth just going into to say the way that a vaccine trial establishes that the vaccine works is you give the vaccine to a bunch of people, and then you give a placebo to a bunch of people, and you wait and watch and see how many get infected in each group. And so if many more people get infected in the group that got the placebo, and many fewer people get affected or get infected in the group that got the vaccine, then you know the vaccine's preventing them from becoming infected. That's just the way they work. And when you have a rare disease, where it might take years and years to get enough to show a statistical difference, that's one thing. But when you have a disease where there's, you know, tens of millions of cases around the world now, it doesn't take too long to get to, you know, 150 or 200 cases out of 20,000 people. And that's really enough to show the statistical difference. For example, the Pfizer one, they had 150 something cases in the placebo and like 6 cases in the vaccine over months and months. So that was enough to show the statistical difference.
That's probably another good thing to talk about, Dr. Jameson, is the amount of people that went through the test. Because, for instance, myself, I thought it was a small test group, but after talking with you, you've explained that this was actually a very large test group that went through this.
Yeah, so that's a good point as well. And again, I don't think people necessarily need to take my word for it. I would prefer if people just, like you said, do their due diligence. Well, here it is. This is the phase 3 study out of the New England Journal of Medicine. This is the data on the Pfizer vaccine. And this is the article I read to make my decision about whether or not I would receive the vaccine. So here it is. And I'm happy to have Jasmine put it up on Target Solutions or whatever you want, but here it is. The easiest thing to do if you want to just cover it quickly without getting lost in a lot of details is just read the abstract here, which says, we had 43,000 people in this study, which means about 20,000 in each arm, right? So 21,720 got the vaccine and 21,728 got the placebo. And over their study period, 8 people who got the vaccine got infected, and 162 people who didn't got infected. So therefore, 95% effective, because 95% less infections among the people who got the vaccine. I mean, it's literally that straightforward. We gave a bunch of people the vaccine, we gave a bunch of people placebo, and then they go about their lives, and we watch and wait and see how many get infected in each group. So that's where you get 95%, effective. Does that make sense?
Mm-hmm.
And the reason it took so long, so remember when Dr. Shepke came on and was talking about this, we were able to develop this vaccine way quicker than other vaccines because we just read the code of the virus and picked which protein we wanted to use, which is the spike protein, because we thought that was the most important one. And we took that and we used what is sometimes referred to as, I guess what's been used in terms of treating cancers for the last several years, where we go ahead and inject the code for that protein, allow your body's own machinery to make that protein. Now, it's not going to go into your DNA or anything like that. It's just going to go into your ribosomes and make the protein. And then that protein gets popped out and your immune system goes, hey, wait, this shouldn't be here. And you start making an immune response against it. So you don't get infected with the virus. You don't get all the symptoms. You just have your immune system go, hey, why are we making this thing? I just saw this thing show up on a cell over here and it shouldn't be there. So I'm going to mount an immune response to it. So it's a way of teaching your immune system about the spike protein without you having to be infected. And that's all these mRNA vaccines do. And they're packaged in a little, you've heard of the lipid bilayer nanoparticle. That just means a little glob of fat, so you can inject it and it is soluble enough. And then that gets pulled into the cell, goes into your machinery, makes the protein sticks out, your immune system recognizes it and goes, that's not right, and we can learn how to deal with that. So that's how these work. But yeah, 20,000 in each group for the Pfizer. Now, they followed them for quite a while. The first vaccine went in a phase 1 trial of this 63 days after we had sequenced the genome, which was way back in the spring. And we've been following people that have gotten the vaccine ever since. They had 2 criteria they had to meet to get to the point where we felt like it was a good study. One is you have to have enough people get infected, right? So you have to have enough of the disease get challenged to see if the vaccine prevents it. And 2, you had to observe people for at least 3 months afterwards to look for adverse effects and all that kind of stuff. And so they met those 2 and then they submitted their EUA. So that's the deal. That's the Pfizer one. And the, let me see if I can show the, and here's the Moderna one. again, tens of thousands of people enrolled. So this isn't actually the article I'm looking for on the Moderna, but you get the idea. These are big studies, well done. And, if you paid attention to what the CDC, the FDA, the Advisory Committee on Immunization Practices put the folks from Pfizer and Moderna through before they would approve these things, the rigor they made them demonstrate, I think it was very clear to me that there were no shortcuts taken. So,
I think that was a very clear explanation. A lot of people are reading headlines and are not diving into these articles. So we can provide them a folder on Target Solutions with all of these articles in there if anybody is interested. Another thing, when we had the vaccine available to our responders, I think there was a lot of people that had already decided they wanted it. And after they saw how many people received the vaccine and didn't have any side effects, I think there's people that are having regrets that haven't received the vaccine and are interested now. So do you want to talk at all about how it felt to get the vaccine and if anybody had any side effects in our population or in any others?
Sure. I got the vaccine, and I got it a few days before it was available to the medics here, only because that was when TGH scheduled me to get it. And I think it's human nature to have some amount of anxiety or nervousness or concern about the unknown. This has been one heck of a year. We've all learned a lot of words that we never knew before. We all have dealt with things that we never dealt with before. And so, we're all probably a little bit on edge from that. And, I think it's normal to have some hesitation or some, I want to see what happens kind of a feeling. I think that's very normal. I think that's how humans work. I made my decision by reading the literature, looking at the data, looking at that versus my potential to be exposed versus my potential to have known or unknown complications, and versus my potential to pass a virus to my family. My parents are in town here. They moved here in February. My dad is and my mom are both kind of older, and I would love to be able to hug them again. I haven't done that since they moved to Florida in February, and that's part of my motivation too. I'm sick of sitting 10 feet apart from them on my back patio as the only time to see them. I'd like to be able to have them come in my house. I think there's motivations that can be any number of things, but I do think it's human nature to have some, nervousness. So, I think everybody needs to make an informed decision for themselves. And I just want to make sure that we do everything we can to provide people accurate, truthful data to make that decision on. So I think we should put the phase 3 study articles on Target in a folder for everybody to see, Jasmine. So I'll make sure you have those if you don't already. But I want to talk about one other thing as well. Let me just see if there's any. Okay, so a couple people saying they had no reactions or no symptoms. So I think it's important when you're talking about the vaccine and reactions or symptoms to speak correctly about what you're describing. So developing a sore arm, a little bit of fever, some fatigue, a headache, some general constitutional things, that is not an adverse reaction to the vaccine. That's your immune system doing what you want it to do, right? So that's called reactogenicity. And that means that you did this thing, you turned on your immune system to work, and your immune system is doing the things that it's supposed to do to fight off, this foreign thing. Now that's different from an adverse reaction like we sometimes saw in older vaccines like Guillain-Barré syndrome or other neurologic complications. That's different from an adverse reaction that you've heard a lot of talk about, anaphylaxis. Those would be true adverse reactions, which is very different from, reactogenicity. Now, if you go get a flu shot, most people have a little bit of a sore arm for a day or two after a flu shot. That's not an adverse reaction. That's your body doing what it's going to do. Same for a tetanus shot, right? Everybody knows that a tetanus shot leaves you with a sore arm for a few days. And that's not an adverse reaction. That's just what it's doing. So I think it's important to sort of separate those. For myself, I had the vaccine. I had no immediate issues with it. The next day, I was a little bit fatigued. I had a very mild headache, and I drank, an extra cup of coffee and took an Advil, and I was fine. My wife had about the same thing. Dr. Smith got the vaccine, and he told me he had a little bit more in the way of chills the next night, but he says he gets that with the flu vaccine as well. Dr. Nassar had the vaccine, no side effects that she reported to me. So, at this point, as of yesterday or today, over 100,000 people have had this dose in the state of Florida alone in the last 2 to 2.5 weeks. And we have very, very few, if any, reports of any kind of real reactions. So, if the 20,000 wasn't, enough for you, literally it's like 110,000 in Florida as of yesterday that have gotten their first shot of the Pfizer with almost no issues known at this point. I do think for those who are really hesitant that, we are watching this thing really closely. And if things do start to pop up as maybe a problem, you'll know about it quickly. You really will. So if you're not hearing anything, it's not because we're not looking. I promise you that. We are looking. I've heard of one or two sort of anaphylactoid reactions where there's sort of allergic reaction looking stuff. Nothing that was particularly major. One or two people out of the 6,000 that got vaccinated in the nursing home campaign, a small number ended up transported, but none of them had true allergic reactions as far as I could tell. There was some people who had, maybe a little lightheadedness, maybe a little near syncope, sort of usual reactions to people getting injections. Some people just don't like shots and they pass out at the doctor's office when they get a shot. So, I didn't see anything particularly out of the ordinary. And even when we were doing literally thousands of people in a day, it was like one or two. So I really haven't seen anything, and it is not for a lack of looking.
Dr. Jameson, I just want to also maybe bring up another point that I think might be somewhat of a misnomer. I think there are some folks that think that as soon as they get the vaccine shot one, they are immediately immune. And that is, that's not correct. And some other folks may be thinking that because you received a vaccine, that you no longer need to wear a mask or practice any of the CDC guidelines. And that's incorrect too. And it might be helpful to maybe speak about the concept of receiving the vaccine and then over the period of, the next, 2 weeks that your body, produces the antibodies that it needs to help you become more and more immune, if that makes any sense.
Yeah, that's a great point. So you have to give your immune system a chance to do the work. Chief Tedesco, I think, was listening in on the Eagles call today, where some of you know Dr. Antevi, whose Hantevi system we use. But Dr. Antevi has been doing a lot of work with antibody testing through this, and he has been testing himself for antibodies every day since he got the vaccine. And it was today, day 12, since he got the vaccine, where he first started showing a faint positivity on the antibodies. And that makes a whole heck of a lot of sense, and I'll show you why. Here it is. This is that same article, the phase 3 study for the Pfizer. So this is days after dose 1 on the axis here, and this is number of cases. Okay, so the blue is the placebo, the red is the people who got the vaccine, and you can see they go along right together right up until about day 12. Here's a blow up of that, right up until about day 12 or so, and then it flattens off. So it does take some time for your immune system to develop that ability to be immune. I mean, what you can see is it's also not 100% because there are a very small number of cases. These are those 8 cases here versus these 160 something cases. So we will all continue to have to take precautions at some level. Clearly, in the early stages of our vaccination. Now, day 21 marks when you're supposed to get the second shot. And they say about a week after that is when, Pfizer says, okay, you should be pretty well covered at 95%. And that was exactly what it said in the abstract I was just showing you a minute ago. But yeah, so we're all in this. I think I'm day 12 or so right now. And so most folks are probably, day 7-ish, somewhere between 6 and 8, that got it at the beginning of last week. So you are not protected yet. And that is a very, very important point. I would say this is going to be individual. So don't, put a hard number on day 12. Everybody's immune system works at a little bit different pace. So not until a week after the second shot, I think, is a good point to consider that you've probably got a reasonable protection. That being said, what we don't know yet is if that protection, we know that protection prevents you from getting sick or significantly sick with COVID. We don't know 100% if that protection prevents you from being able to asymptomatically pass the virus yet. And we'll know that pretty soon. We just don't know that quite yet because, we have to wait for the data.
Have they figured that out off of the studies? If any of them were where they had the antibodies, then they lost them, and then they became more susceptible to the virus again? And I'm noticing, I'm looking at the study that you're showing on the screen right now, and that's days after the dose 1. So if we're getting such a good coverage after dose 1 at 12 to 14 days, why 21 days after dose 1 are we reapplying another dose? Is there a reason? Are they saying the effectiveness of the first dose is not going to last, and that's what the second dose is for, is to kind of boost that first dose? And I know one of the things we've talked about before, and I've talked to you personally about this, Dr. Jameson, is what is going to be that, how long is this vaccine going to really protect us?
Sure. So if you look down here at the number on the bottom, this is exactly the data you're asking about. So after dose 1, you have a certain amount that is protected, but that may wane a little bit after the initial thing, and then you drop down a little bit more. So after dose 1, but before dose 2, and then dose 2 to 7 days after dose 2, you're probably in that range, and then 7+ days after dose 2, you're in this range. And the way they establish these numbers is just by watching and seeing what happens in this population. You can see that there's a couple of cases right in this neighborhood that represent, those numbers. So, there's no magic behind it. It's just, this is what happened to those folks that we were watching. Now, knowing about the asymptomatic transmission, you'd have to be watching the family members or the contacts of the people in the study. So we don't have that yet. That we'll know once enough people get vaccinated and we start to see patterns. But we don't know that yet. Does that answer your question?
Yeah, and isn't the CDC or I think it was Pfizer, I'm not really sure who that was speaking, which we talked about before. They were talking about without 65%, vaccinations of the population, that they still would recommend that everybody continues to wear face coverings and practice social distancing.
Yep. So herd immunity is the concept they're getting at there. So the idea is that you have to break the chain of transmission, right? And you can break the chain of transmission any number of ways. One, you could, go in your cave and never come out, so you would never be exposed, right? But that's not really feasible. And we know that so-called lockdowns don't have lots of other consequences and aren't necessarily as effective, as they might be. So there's other tools. So one tool is a vaccine to try to interrupt that chain of transmission. If you can say that, instead of you being able to infect 100% of the people you come around, maybe you can only infect 5% of the people you come around. Well, that does a lot to break the chain, right? But then you can also have a mask there, and you can say, well, if the mask drops it by another 30%, even in those unvaccinated people, that's helpful as well. So you got to think of it as sort of lots of strategies put together, and no one strategy in and of itself is going to do it. So we got to have all of these things coming together. We've got to practice appropriate distancing in terms of not sharing air with a lot of people when you don't have to, using barriers like masks and PPE, and then decreasing our own susceptibility by getting the vaccine. So you do all those things, ideally, you get the R naught less than 1, and the curve starts to go down, and we come out the other side of this thing where the virus, somebody gets infected with the virus and they never are able to pass that infection to somebody else. That's, everybody, that's the only way that the curve goes down, right? Is if you get infected, but by a combination of people around you having vaccines, you wearing a mask to decrease the amount of virus you're shedding, other people wearing masks to decrease the amount of virus they're exposed to, all of those things together, you have to be able to get the virus and not infect anybody else. And that has to happen over and over and over again so that the virus stops at you. And so that's the concept of herd immunity. Once you have that, where the chain keeps getting interrupted, then less and less infections happen. And then, you sort of get a benefit by everybody has less exposure, and then it just continues to snowball until you're pretty much done with it. But it takes multiple strategies to break that chain. And I had my vaccine. I'm still wearing an N95 mask for every darn patient I see, because I'm not done with my series yet. And even when I am done with it, is 95 okay, or would I like 100? Well, I'd like to get as close to 100 as possible. Does that answer? I can't tell if Lieutenant Glenn froze or if he's still there. Don't make me hold up your high school picture.
I'm still. Oh no! Don't pull that thing out, please. Well, I mean, I know that I still have some reservations, and we've spoken about this, and and my reservations are, and I think that was one of the things we've been trying to talk about, is that hey, this was a very rapid vaccine that was developed. It wasn't really tested as well as a lot of us would really want something to be tested. I mean, I know it has been, but in our minds,
and I'm going to push back on that a little bit.
No, I want you to
tested just as well as any other vaccine you've ever received.
Okay, so to a lot of us, when you look at a lot of the studies of how long it took to develop certain vaccines and the years and years and years that it took to see something that was developed so quickly, it, like, for me, it just put a little bit of like uneasiness into me about getting this first dose. And like I talked to you, I want to see, what are the side effects, and I don't want to say side effects, maybe the adverse reactions that people may have from that second dose. And that's, that was my plan. And we talked about this before, that
the one thing I want to ask, though, if you think about it, put it in context, how far have we as a society come technologically? If you think about how fast technology has increased, I mean, the concept of having a CD and putting a CD in a computer is almost non-existent. We have computers now that don't even have those CD readers. The point I'm making is that science has been there all along, and it's actually not based on new science. It's actually old science, but now we have the technology to actually do what we're doing. And to be honest with you, the way that please correct me if I'm wrong, Dr. Jameson, but the way they made that vaccine is going to change the way medicine is as a whole. It's changing medicine, the way we treat the way we will treat all sorts of diseases. Cancer, I think, is going to be looked at much differently now. Things along those lines. It's changing the way we do medicine. No one should be shocked at how far we have come medicine-wise. We're not shocked how far we've come technologically speaking. Why are we so shocked that we've come this far medically speaking, if that makes any sense?
Yeah. So maybe just to tack onto that, how did we used to make a vaccine? Well, we had a couple of options, right? We could take the actual virus and do something to it to inactivate it or make it weaker, and then give it to you, right? So would you be comfortable with an inactivated or an attenuated COVID? Most of us, probably not our first choice. Okay, what's the other way? Well, you can the other thing you can do is try to find a similar virus that doesn't cause sickness. So in case you didn't know, the the smallpox vaccine is vaccinia virus, which is cowpox, right? So they found another similar cousin of smallpox that doesn't really cause that bad an infection, but has cross-reactivity with the one that causes the really bad one. So I'll just infect you with that one, and then you'll be protected against the bad one. Again, maybe not the ideal strategy that we want. So, the other things you could do is then go in and like genetically engineer various viruses to try to make them not work as well, but still cause your immune system to do a response. So you have sort of genetically modified viruses that you then still inject into people and try and get a response. All of those are sort of trial and error like strategies. And involve a lot of time. So that's one thing. The second thing then is remember how many cases are out there in the public. Just because there were so many cases is one of the reasons why it was so fast. But maybe this is a helpful thing to show real quick. Maybe not. I don't know. Let me try. Sorry, 1 second. Let me just get the right window up here. So I'm just going to open a browser window, right? And I'm going to so I can literally Google in here and find the exact structure, and I can even put in and go into, of course, now it's not pulling up for me on right now, but there's like a database where I've done it before, and I can go in there and pull up the exact structure, amino acid by amino acid, protein fold by protein fold of this thing, and do it like that. And then I can put it in this little 3D viewer that the government has available to everybody now. And it's, by the way, it's been there since I was in college 20 years ago. That's how I used to do my molecular biology homework in college, right? So we have the exact code, and there's no more need for trial and error. We know what it looks like, and we can just build something that does it. And the fact that we've spent the last couple of decades doing things like the Human Genome Project, the fact that I can sequence an amount of DNA today in a few hours that used to take months, means that we could go faster with this. And Chief Tedesco is right. I think that the vast majority of all vaccines going forward will use this technology.
I think it's natural when something is new and unfamiliar for people to be nervous and be searching for more information. And with social media and conspiracy theories and all of the things that are going on out there, a lot of people are hesitant to begin with. But going back to the very beginning and understanding how vaccines are the biggest thing that we've done in public health to prevent preventable diseases, to prevent diseases, I think that's important. And giving people the knowledge to be able to arm themselves with that when somebody comes to them to explain to them why they shouldn't be getting this vaccine. We have a lot of people in fear of vaccines because they're unsure of what they're putting in their body. And if you look at vaccine hesitancy in general, it's based on lack of information. So people are searching for that information, and we're trying to give you guys as first responders that information, because the community looks to their healthcare providers for the information that they need to make those decisions. So if you don't have the information that you need to feel comfortable with this vaccine, come to us or somebody who has that information to get that information. This isn't just about you guys vaccinating yourself and keeping yourself safe and protecting the people around you, but people are going to look to you to get the information to make decisions for themselves as well. I'm sure that in the back of an ambulance that there are regularly patients asking responders about this vaccine and how they feel about it.
Yeah, I suspect that's true. I also would encourage you to ask, your grandparents or folks who were alive back during polio, about, what it took to get a polio vaccine and how much suffering there was before they got one. I'm going to put up one other thing this is from Dr. John Ju, who's the medical director out in Portland, but is also a damn smart guy when it comes to all things infectious disease. And this is a little diagram of kind of how this works. So you have the mRNA that you inject in the little lipid nano thing. It gets pulled into the cell. Your cellular machinery makes that protein, in this case, the spike protein, and it gets stuck right here. It never goes in the nucleus. It never goes near your DNA, anything like that. It gets stuck out here on the membrane. And then your immune system with your various types of T cells and everything else comes by and you start mounting an immune response for it. So it literally takes advantage of your natural cell machinery to take this little thing in here. And this, you can think of it like the software code, or if you're a 3D printer guy, this is the code for the whatever you're printing. This is the printer, and then it sticks it out here and your immune system recognizes it. That's how these mRNA things work. And you can see, if I know what I'm looking for, if I know the code for this protein, it's super easy to just put that code in here and let your cell do it. Does that help conceptually? I don't know. So there's a few more questions in the chat. So I don't know when we're going to get the next availability for additional people to get vaccinated. Now, if you got vaccinated last week, you will get the second shot around 21 days. There's a few days wiggle room, but they've committed. They wouldn't have given us the first if they couldn't give us the second on that. So you will need to get your second shot to be fully protected, and that should be coming. Very few people around here have had the second dose yet. I think I got mine on the 4th day. They were offering it at TGH, and that was really the first in the community to go. So I think next week we'll start to see people getting their second shots, or maybe the week after, and then we'll see more. But if you look at the we pull up the data, so we're not just talking, opinions. Let me share my screen again with the actual data from the study. So here's the data on who they gave in the safety population. So you can see it was split pretty evenly, male, female. There was a wide variety of ethnicities represented. This was a multi-international study, so there were other countries involved. It wasn't just the US. You can see that there was a good number of people who were elderly, or not just young, healthy people. And you can see there was a good number of people who were obese, which is obviously one of the significant risk factors for having severe infection or illness. So this is dose 1. Again, most things are mild and moderate, really none severe in grade 4 or very low numbers. Fatigues, headaches, chills, muscle pain, that kind of stuff was most of it. And you can see it was more in the vaccine than the placebo. And you can see that it was maybe a little bit more in dose 2 than dose 1 as well. Particularly soreness, redness, swelling, those kinds of things. But if you're interested in these, this data is here. It's public. You can look at it and make your own decision. Here's use of medicines like Tylenol or Advil. How many people in this age category after dose 1 felt like they wanted to use some Advil or Tylenol for their temperature, and you can see how many after dose 2. So it's a little bit more, and there's some other ways this data has been presented that's a little bit easier to read. But yeah, so you maybe, like I said, you take a little Advil or you take a little Tylenol. These are the types of things that people were having. See all the lists down here on the bottom. So fever, fatigue, headache, chills, vomiting, diarrhea, muscle pain, joint pain, and use of some antipyretic, which just means anti-fever medicine. And this is with them like actively asking people. They were asking them every day, you know, how you feeling, et cetera. So this data is here. It's actually in a nicer graph in the Pfizer presentation to the FDA. It's the same data. They just made it look prettier in the other one for discussion purposes. This is a very scientific paper that's showing the data, but yeah, there's going to be some more reaction to the second shot than the first one, and that makes sense. Your immune system's primed already for it, and it's going to spring into action with a little bit more authority on that second shot. Lieutenant Glenn, you look like you have a question or concern.
Yeah, I have a question, right? So I was going to ask you, like in that study, I saw that obesity was one of the things that they were kind of looking at in age groups, and they did all ethnicities, male, female, all that other stuff. Was there anybody in there that was like had pre-existing health conditions, heart problems, respiratory, asthma, anything like that? Did they have any side effects or adverse reactions to the vaccine? Like if they took any types of cardiac meds or respiratory meds?
Yeah. So they excluded a few categories of people. Like they didn't intentionally enroll anybody who was pregnant. They didn't intentionally enroll anybody with active HIV. But they certainly did have people with lots of other medical thing. And I'm struggling to find the document right now. David Hudak, if you happen to be listening and want to send me that graph again, because I'm struggling to find it in my folder here. But yeah, they had lots of different folks in there with particularly with high blood pressure, high cholesterol, diabetes, all that kind of stuff. So there was
I believe they just cleared pregnant females as well. Is that correct?
Yeah, so there's a question in the chat about pregnancy. So for our for the state allotment that we were given last week, that we were given access to, for the state mission, they did not want to include pregnant people. That was primarily a mission that was targeted at nursing homes or skilled nursing facilities. And so they had more contraindications or exclusions than even Pfizer needs. So there is very consistent guidance coming out that pregnant people may take the vaccine. The exclusion on the initial one was really because they didn't intentionally enroll anybody who was pregnant. Now, they did have some people who became pregnant during the trial with no significant effects. And certainly we know that getting sick with COVID while you're pregnant can be a really problematic issue for both mom and baby. So most people are saying, talk about it with your OBGYN and make a decision. There is a position statement from the American College of Obstetricians and Gynecologists that says it's okay. And most of the pregnant doctors that I know or have heard of have decided to get it. So the only reason it was excluded in this particular thing last week was because that was part of the parameters of the initial mission from the state.
Yeah, we have a young lady who's pregnant who asked her OBGYN and also said, please take it.
Yeah. So again, I think that's the type of conversation you want to have with your OBGYN, but there is nothing to my knowledge that says that you shouldn't. It just simply wasn't part of this initial allotment, given the parameters we were given by the state. So we talked about higher reaction on the second dose. There's a question about the public signing up. The details of that are still to be announced. Like most things with the state these days, it's a little bit last minute. So as soon as we hear, we'll let you know. But at least on the call I was on with all the hospitals about how they're doing their vaccination stuff as of this afternoon, there's a lot of details still to be worked out. How long will the vaccine protect an individual that gets it? Now, that's a great question. And I think to a certain extent, the answer is we don't know fully yet. Now, I think it's reasonable to expect that it will, based on what we know, absolutely be effective for 90 days. And I think that there's a good bit of data that's going to show that it's more like a year or two. And so whether or not you will need a booster shot in a year or two remains to be seen. And there's probably going to be a lot of factors that go into that. One is the efficacy of the vaccine. Two is how many people get the vaccine and whether we still have a high burden of the virus in our population. So obviously the more people that get the vaccine, the more we can knock this thing down, and then there's less of a resurgence.
Didn't Dr. Ju say that they pushed it out to 6 months today for now?
Yeah, so as the data rolls in, they'll keep pushing it out. I expect it'll land somewhere a year, 2 years, if not longer.
Yeah.
But we don't, the answer is we don't know exactly how long yet. It remains to be seen. And, could it be that you get a corona booster every year, just like you get your flu shot every year? It could be that in the future. That's a definite possibility. We don't know that yet. Okay, so yeah, so Julie piped in the chat that she generally doesn't like getting vaccines, but she did have a little bit reaction 24 hours later. It doesn't sound like it was particularly serious. So yeah, I mean, there are some people who should definitely talk with their doctor before they get it. If you're immunocompromised, it's not that necessarily the vaccine will do anything bad to you, but you may not mount an immune response that will result in protection. If your immune system really isn't working too well to begin with, the vaccine may not actually cause you to develop, protective antibodies and T cells and all that kind of stuff. If there's a few other conditions that are out there, if you're on blood thinners, you can theoretically get like a hematoma at the site of the injection. I mean, there's various other little things like that. So if you have a question about it, if you're concerned that you might fall into one of those categories, then I would highly suggest you just talk directly to your doctor and make a decision together about what you think is right for you. All right, what other questions do we have? I guess the other thing I'd say is I don't know when the next chance we are going to have to add more people that desire to get the vaccine among our EMS folks. We were very lucky to have the opportunity to get those vaccines last week. That was very fortuitous, and we are one of the among all the vaccines that have been delivered in the state of Florida, we've delivered in our county quite a number of them. So I'll show you this if I can. And then there's one last other thing I want to show you all. Sorry, I've got like 6,000 different windows open. Okay, I found it. I don't know what's going on with Chief Tedesco over there,
Yeah.
but something is.
Figured there was an animal down there.
Yeah.
All right, so if you can see this is as of yesterday or the day before, and we've given 122,881 vaccines in the state of Florida. Nobody has finished their series yet, but this is the number of vaccines that were administered by day. So to those who want to see more data, I mean, we administered more vaccines on the 23rd of December than the entire 20,000 people in the study. And we're obviously not alone. This is happening in every state. So, we are watching very closely for adverse reactions. And if there is a signal there, we would have seen it already, or we'll see it very shortly. You can see the leading counties. So Broward County, Dade County, Duval, Orange, and we are right up there at almost 10,000 given already as of a couple of days ago. So, we've given it to 10,000 people in the last week just here in Pinellas, and I don't think anybody's heard of lots of people having problems with it or suddenly having better 5G reception. That was a joke for you, Lieutenant Glenn. All right, so let's see what else we got, because I got one other topic that I want to cover. So let's just see what else we have in terms of the comments. So somebody said, what resources would you suggest to show your coworkers that may be anti-vax or conspiracy theorists? I mean, there's data. Data is all you got. You know, go to the primary source data and make your own decision. Expert opinion is great, but expert opinion only goes so far. Most of us want to know for ourselves. I think I said before, trust but verify, right? So, you know, I want to read the study. I want to see what happened. I want to see who was in it and who wasn't, and all that kind of stuff. And I think I've been very satisfied that both of these vaccines, the Corona or the Pfizer and the Moderna, have gone through just as much rigor as any other vaccine that we use. Another person asked, will we get the Moderna vaccine? I think there's a good chance, but I don't know for sure which next vaccine we'll be able to get. There is Moderna vaccine here in Pinellas. Some of the hospitals have received it and are using it for their staffs. And I suspect that there'll be a lot of Moderna distributed to the public as well as we start to work on the over 65 population. Bear in mind that the over 65 population in Florida is like or just in Pinellas is over 250,000 people. So it's not a small amount. All right, let me find the last thing I wanted, because it's already getting kind of late here. And I just want to bring this other one to everybody's attention, which is this. So we're beginning to see some concern, and I may have mentioned this a while ago when the first ones came out, but we're beginning to see some concerns about, this is the one I'm looking for, young, healthy people with mild or asymptomatic infection who are ending up with long-term cardiac implications. This is one that's a little bit goofy, and it's related to sort of an inflammatory response in the heart. And essentially, what this is getting at is that they did some studies with collegiate athletes, so young, healthy athletes, where they did a special kind of MRI of their heart, and showed what might be myocarditis among these folks, and particularly among asymptomatic and mildly ill people, to the point where they are now recommending that even young, healthy athletes who had a fairly mild or asymptomatic infection may benefit from a full cardiac evaluation prior to being cleared back to athletic competition. So they're seeing heart failure, chest pains, elevations in troponins, arrhythmias, EKG changes, changes on the functional MRIs. And so they're talking about, you know, a fairly extensive cardiac workup here, including EKGs, Holter monitors, stress type testing, et cetera, on anybody who might fall into those categories. Now, I'm not sure that they're recommending that for every you know, asymptomatic infection, but if somebody even has a little bit of one of those symptoms, they're now recognizing that this may be a problem. And I don't think we know how permanent those symptoms are. You all may remember that when this thing first started, and a few of the first doctors that got this, I told you about a doctor from the Tampa Bay area that I know that was an avid runner. and had a resting blood pressure in the 100s over 60s and a resting heart rate in the 40s and 50s, got this infection, and months later still had a resting blood pressure at 140 over 90 and a resting heart rate in the upper 80s to low 90s. There's something happening in the cardiovascular system that we don't fully understand yet. So if you consider yourself an athlete and that is something that would potentially trouble you, all the more reason to consider protecting yourself from that possibility, because even though you don't end up sick right away, there is the possibility for downstream complications that we don't fully understand yet.
Are they thinking that this might be more of a immune response to the virus or the virus itself causing this?
I think it's still a little bit unknown, but it's certainly an itis or an inflammation in the heart. And they've done some work where they actually were taking tissue samples after folks have died, looking specifically for virus in the heart muscle. And then a lot of it, thankfully, has not been people that died where they were able to see the inflammation. So we don't know exactly whether the virus was in that tissue or whether it was a reaction to the virus. But I think there's some data out there of direct involvement of the heart by the virus. So, another thing, we continue to learn about this virus every day. And you all have seen firsthand, the world has seen how evolving science can be messy over the last year with differences of opinion and differences of interpretation about what the data is telling us. But I think we should not be at a point now where we feel like we understand this virus, because 10 years from now, we'll probably have a very different understanding of it. So in any case, that's the major stuff I wanted to cover today. I just wanted to try to keep answering questions to make sure that people were looking at primary data sources. So if you're going to, go do your homework and your due diligence to understand and make a decision, please make sure that you're going to, reputable, peer-reviewed scientific data. It doesn't get much better than, the Lancet or some of these other, New England Journal type sources. I mean, there's had multiple experts pick them apart and they still managed to get published. So, I think you should consider those to be reputable sources. And I would encourage everybody to, read it yourself, look at the data yourself, understand what they did and how we ended up where we are. And ask questions like we're doing here. Ask questions. Go to people who you think have an informed opinion and ask questions. All right, so here's another question that just came in. So is this covered under the heart and lung bill for firefighters, and is this considered a work comp should it come up? It's funny that you asked that question, because I heard today in a call that there is currently discussion about whether or not this would be covered. And the linchpin of that discussion is, did you do everything reasonably possible to protect yourself? And if you were offered a vaccine and declined it, then there's some discussion of, then you didn't do everything reasonably possible to protect yourself. So that is an active point of discussion right now. And I'm not a part of those discussions, but I heard from other people that they're going on. Yeah, heads up, that's a real issue. That's a very good question, and the answer remains to be seen. I was talking to somebody else about this today, because I recognize that as a big deal when I heard about it. I don't know the answer. What happens if you decline your hepatitis vaccine and you contract hepatitis after a needle stick? I don't know the answer to that, but I mean, it's sort of kind of similar, right?
I believe you have to prove that you're not part of the 10%. You've gone through 2 trials of the hepatitis and that the vaccine did not take, and you're covered. So
what if you actually decline the vaccine?
Well, then you have a problem under the presumptive bill.
That's what I'm concerned about, right?
Yeah,
I think that's
absolutely.
a discussion that's beginning right now, and people should be aware of that. So, I think it's worth noting we've been exceptionally lucky here in Pinellas. I was on the phone earlier today with a medical director from Kansas City who's fighting to get vaccine availability for her firefighters and medics. And she's sort of beside herself because they just got pushed back to the next group down or whatever it is. And, you know, she's trying to make the argument that they've had 3 line of duty deaths and multiple other people end up on ventilators and somehow they're not in the priority group. So, you know, if we're offered it again, I would highly encourage you to think very carefully about whether or not you want to get it. And, you know, I've committed to share with you my decision-making process, which I hope I've done at this point. I did, in fact, receive my vaccine a little while ago, and I'm grateful for the opportunity. There you go. There's me getting my vaccine. I'm grateful that I had the opportunity to receive it, and I'm very grateful that the state made some doses available to us last week as well. So I think I'll stop there and take any last questions that are coming in. I know we haven't done one of these in a few weeks, but things have been moving fast, and we got instead of covering the vaccine stuff last week, we actually started administering vaccines. So, all right. Last chance, anybody put up additional questions or concerns? I would say don't hesitate to reach out and call if you have a specific issue you want to discuss. And you know, make sure you're being informed and knowing what the impacts of these things are to you and your family. So Matt asked, when do we expect the general population? Matt, I think it's going to be phased just like everything else. So they're going to start with folks over the age of 65. I hope that starts in the next week or two, but I don't know the answer for sure. It may be a couple months before a non, healthcare worker, first responder, young, healthy person gets it. I suspect that'll be a couple months, but I don't know for sure. Chief Tedesco, anything to add? Final thoughts?
No, I just encourage folks that did the vaccine or when the vaccine comes around again, that you strongly consider taking it if you haven't already taken it. Definitely a wise thing to do. If you have any questions, then reach out the way Dr. Jameson said, because there's certainly a lot of people who have very good information to give you. Please be safe, everybody. And whether you've got the vaccine or not, make sure you protect yourselves and have respect for your coworkers and anyone else that you're around. Wear a mask, wash your hands, and physically distance. Happy New Year.
Then Glenn, any final thoughts?
No, I appreciate you, giving me the opportunity to be on this. I hope I asked some questions that may have, and there it is. Go ahead. You
That's brutal, man. That's
yeah.
brutal.
So no, I appreciate you having me on this. I like I said, I'm not the naysayer. I'm just I'd like to do my due diligence before I do anything, that's especially something that's new that's out there. So like Chief Tedesco said, I encourage everybody, do your research on it. Come up with your plan that you want to do. If you decide to get it, then good for you. If not, you need to be making sure that you're doing your social distancing, wearing your mask, and doing all that stuff that like he was talking about. And a Happy New Year to everybody.
Great. Jasmine, any final thoughts? Hashtag 2020, you're muted.
I'll get this information on Target Solutions. Just keep yourself informed. I know there are people who wanted this vaccine that were unable to get it. When we get more vaccine, you guys will hear about it. You might get 20 notifications on Target Solutions, but just keep watching. We'll make sure that you guys have everything that you need. And stay safe out there.
Okay, I don't see any further questions in the chat. So at this point, I think we'll go ahead and close it out. It's been a little over an hour. Thanks everybody for doing this. Thank you to Lieutenant Glenn and Chief Tedesco for coming on and sharing your insight and thought process. And like they said before, Happy New Year and stay safe out there.